Hello everyone. In this video, we'll try to learn the interpretation of liver function test. So these are the parameters which encompass the liver function test. AST and ALT denotes hepatocellular markers, whereas alkaline phosphatase, GGT, 5-nucleotidase, they denotes cholestatic markers. Apart from this, liver also synthesizes albumin and clotting factors with the help of vitamin K, which characterizes the synthetic function of liver and gets hampered during the chronic liver disease. These are the patterns of liver injury which we come across during the interpretation. One is isolated hyperbilirubinemia, where only serum bilirubin is raised. All other liver function tests are normal. Second is hepatocellular pattern, where the hepatocellular enzymes, AST and LT, are raised disproportionately as compared to that of cholestatic enzymes. And third, cholestatic pattern, where the cholestatic enzymes like alkaline phosphatase and GGT are raised disproportionately in comparison to that of hepatocellular enzymes. First come first, isolated hyperbilirubinemia, that is increase in serum bilirubin without any derangement of other liver function tests. So whenever this is there, we stratify this into either direct hyperbilirubinemia, when the direct fraction is more than 50% of the total serum bilirubin, or indirect hyperbilirubinemia, where the indirect fraction is more than 85% of the total serum bilirubin. Why this stratification is important? Because isolated hyperbilirubinemia is generally seen in inherited disorders. For example, direct isolated hyperbilirubinemia is seen in Dubin-Johnson and Rotor syndrome, whereas indirect isolated hyperbilirubinemia is seen in Kriegler-Nazar, Gilbert syndrome, and hemolysis. So how to differentiate this indirect hyperbilirubinemia of inherited disorder from that hemolysis? In hemolysis, patient will have the history of fall of hemoglobin levels, as well as there will be rise in LDH levels. For example, here you can see on the left side, the total serum bilirubin is 9.3 and the direct fraction is more than 50%. So we can call it as direct hyperbilirubinemia. Also on the right side, total serum bilirubin is 24.6 and direct 15.8. Again, it is more than 50% of the total serum bilirubin. So again, we can label it as direct hyperbilirubinemia. And this, we can see that serum bilirubin is raised and indirect fraction is around 85 to 90% of the total serum bilirubin. So we can call it as indirect hyperbilirubinemia. The next patterns of injury are hepatocellular and cholestatic patterns. In hepatocellular patterns, hepatocellular enzymes, that is AST and ALT, are raised disproportionately as compared to cholestatic enzymes. Whereas in cholestatic patterns, cholestatic enzymes, alkaline phosphatase, is raised disproportionately as compared to hepatocellular enzymes. Before we learn it further, we'll try to briefly understand the liver enzymes. First is aminotransferases, which are ALT and AST, also known as SGPT and SGOT. ALT is specific for liver injury because it is exclusively contained inside the hepatocytes, whereas AST, apart from liver, is present in many tissues, so it can be raised in many conditions apart from liver injury. So that's why ALT is specific for liver injury. When ALT is specific for liver injury, it is raised higher than AST in most of the liver disorders. So always in most of the liver diseases, AST by ALT ratio will be less than 1. Why? Because ALT will be higher than AST and ALT is the denominator. So AST by ALT ratio will be less than 1. But only there are few liver disorders where AST is more than ALT and thus this ratio will become greater than 1. These are alcoholic liver disease, end-stage liver disease, which is cirrhosis, and Wilson's disease. Also, we should remember that AST and ALT will never be more than 400 units per liter, whether it is alcoholic fatty liver disease or non-alcoholic fatty liver disease. How to differentiate between alcoholic and non-alcoholic fatty liver disease? In alcoholic fatty liver disease, AST will be more than ALT, as I have said earlier, whereas in non-alcoholic liver disease, ALT will be more than AST. Also, we should remember that AST and ALT can be raised up to 8 times upper limit of normal. Upper limit of normal of both are around 35 to 40 international unit per liter. But more than 8 to 10 times upper limit of normal raise signifies the hepatocellular injury. One more important thing, that massive elevation of AST and ALT, that is 25 times more than upper limit of normal, that is seen in very few conditions. One is acute viral hepatitis, second is toxin or drug induced liver damage, and third is ischemic hepatitis. So the takeaway messages from this slide is that most of the liver diseases, ALT will be more than AST, but only few diseases like alcoholic liver disease, end stage liver disease like cirrhosis and Wilson's disease, AST will be more than ALT. And also in any sort of hemolysis, because in RBC, AST is present. So in any sort of hemolysis, AST will be higher than ALT. And thus, AST by ALT ratio will be more than 1 in hemolysis also, apart from these three conditions. Also, one more message from this slide is that AST and ALT can be elevated up to 8 times the upper limit of normal in any liver disease, whether it is hepatocellular or cholestatic. But more than 8 to 10 times upper limit of normal signifies hepatocellular or hepatocyte injury. Second is marker of cholestasis. Alkaline phosphatase is the most important. It is present in the cells lining the bile duct, whether intrahepatic or extrahepatic. It is the marker of cholestasis. But apart from liver, it also comes from bone. So how do we characterize that the patient having higher alkaline phosphatase is coming from liver or bone? This is very easy, that whenever other cholestatic markers are also raised in addition to that of alkaline phosphatase like GGT or 5-nucleotidase, then it means this alkaline phosphatase is coming from liver. But whenever alkaline phosphatase is isolatedly raised and without raising GGT or 5-nucleotidase or without any abnormal liver function test, then the liver etiology is unlikely. We must also remember that apart from alkaline phosphatase, GGTs and 5-nucleotidase are also cholestatic markers, which also rise along with alkaline phosphatase in case of any cholestatic or obstructive injury. Few things we should remember about GGT, that it rises in all pancreatobiliary conditions where alkaline phosphatase is rising, but because it is not present or rise in bone disorders, in contrast to alkaline phosphatase, so it gives organ specificity to alkaline phosphatase. That means that whenever alkaline phosphatase is increased along with GGT, then it helps us to know that the source of alkaline phosphatase is liver. And apart from this, GGT is raised out of proportion in alcoholic liver disease, around 8 to 10 times the upper limit of normal. Now, coming back to the patterns of injury, hepatocellular, where there is disproportionate elevation of AST and ALT as compared to cholestatic markers. And what is that disproportionate elevation? That is more than 10 times of upper limit of normal. And the other pattern is cholestatic pattern or obstructive pattern, where there will be disproportionate elevation of alkaline phosphatase as compared to that of hepatocellular markers. And what is that disproportionate elevation? That is more than 4 times of upper limit of normal. Whenever we are not able to stratify the pattern into either hepatocellular or cholestatic, or whenever in any patient both these patterns are present, we call it as mixed pattern of injury. Coming to the examples, in this patient, there is jaundice, there is rise in AST, ALT, as well as there is also rise in alkaline phosphatase. So both hepatocellular and cholestatic markers are raised. But you can see very well that hepatocellular markers are significantly and disproportionately raised. They are actually more than 10 times of upper limit of normal. In fact, more than 25 times the upper limit of normal, whereas alkaline phosphatase, though it is raised, but it is not fulfilling the definition of significant rise because it is less than 4 times the upper limit of normal. So here the predominant injury is hepatocellular. So we can say that this is hepatocellular pattern of liver injury. Now coming to this, here again, patient is having jaundice and AST and ALT are normal, whereas alkaline phosphatase or the cholestatic markers are significantly raised, and that significant raise actually fulfills the definition of disproportionate raise, that is more than 4 times the upper limit of normal. So this is a cholestatic pattern. So here we must remember that when we are dealing with any liver function test report where enzymes are elevated, then the interpretation is not guided by which fraction of bilirubin is raised, where rather than the interpretation is actually guided by which enzymes, either hepatocellular or cholestatic enzymes, are raised. So whenever there's the predominant hepatocellular enzymes raised, then it will be hepatocellular pattern of injury. Whenever it is cholestatic enzymes are raised, it is cholestatic pattern of injury. Now again, here again, jaundice is present, and you can see that both hepatocellular markers as well as cholestatic markers are raised. But you can see that the hepatocellular markers are less than 10 times upper limit of normal. So they are not actually fulfilling the definition of disproportionate raise, whereas alkaline phosphatase is around 10 times the upper limit of normal. So it actually fulfills the definition of disproportionate raise. So this is again a cholestatic pattern of injury. Now, this patient, there's hardly any jaundice, but you can see that cholestatic markers are normal, whereas hepatocellular markers are around 20 to 25 times upper limit of normal. So it becomes hepatocellular pattern of liver injury. Now, coming to this, here you can see that again, both uh, aminotransferases, that is hepatocellular markers as well as cholestatic markers, alkaline phosphatase, are raised. But you can see that the predominant raise is of alkaline phosphatase because it is more than 5 times upper limit of normal, whereas AST, ALT are just around 3 times of upper limit of normal. So we'll again consider it as the cholestatic injury or cholestatic jaundice. This is a tricky interpretation because here you can see that hepatocellular marker, that is AST, ALT, are raised around 20 times the upper limit of normal, whereas alkaline phosphatase, that is cholestatic markers, are also significantly raised, that is around 8 times of upper limit of normal. So both are actually significantly raised. So here what will help us is R factor. What is R factor? R factor is calculated by the formula given ALT divided by ALT upper limit of normal divided by ALP upper limit of normal. If we if we apply this formula in this particular patient, we are getting R factor as 2.2 or 2.3. So whenever R factor is less than 2, then it is cholestatic injury. More than 5, it is hepatocellular marker, hepatocellular injury. But between 2 to 5, it is a mixed pattern. So here it is 2.2. So it will become a mixed pattern with predominant cholestatic pattern of liver injury. Now coming to this, here again there's a jaundice. There's a rise in hepatocellular markers. That rise is also very significant. You can see that around 20 to 25 times upper limit of normal, whereas alkaline phosphatase is also raised. That is again significantly increased. That is more than 5 times the upper limit of normal. So both significant hepatocellular and cholestatic injury is present. Then again we'll apply the R factor. Here R factor is 4.2. It means it is near to hepatocellular injury. So, but it is not 5 or more than 5. So we'll again tell it as a mixed liver injury with predominant hepatocellular pattern. Now, these two interpretations are quite interesting. On the left side, you'll see the serum bilirubin is raised with predominant indirect fraction, more than 85% of the normal. So indirect hyperbilirubinemia with normal liver function test. Whereas on right side, you can see that again indirect hyperbilirubinemia with raised AST and normal ALT. So both are indirect hyperbilirubinemia. So as I have said that indirect hyperbilirubinemia is caused by inherited disorder like Crigler-Najjar, Gilbert, as well as hemolysis. Whereas in inherited disorder, LFTs, all other LFTs will be normal. Like in the left slide, all liver function tests are normal. So it will become an inherited disorder, Gilbert syndrome. Whereas on right side, AST is raised. AST is more than ALT. It means there's hemolysis. It will take the history of the patient. Patient will surely give the history of fall in hemoglobin. So left side is Gilbert syndrome, right side is hemolytic anemia. So this is the, now coming to this, here again, this patient actually presented with fall in hemoglobin from 11 to 6. And you can see that serum bilirubin is raised, and which is predominantly indirect hyperbilirubinemia. AST is more than ALT. Again, it is fulfilling all the characteristic of hemolysis. But again, we should remember few things in hemolysis, that in hemolytic anemia, the serum bilirubin will never go more than 4 milligram per deciliter. And indirect fraction will be higher than direct, that is fine. But direct will be normal. Here, see, direct is also raised. But in hemolytic anemia, direct fraction will be normal. So this, although the patient gives all the manifestations of hemolysis, but few things does not go in the favor of hemolysis. So this patient, though he or she has hemolysis, but also will be having pre-existing liver disease. That's why the serum bilirubin has raised more than 6, and direct fraction is raised more than direct fraction is also raised apart from indirect fraction. This is the last interpretation. You can see that the serum bilirubin is raised. There is rise in hepatocellular markers. Also, there is rise in cholestatic markers, but this rise is not significant neither in hepatocellular markers nor in cholestatic markers. But one thing very interesting, that AST is more than ALT. Again, AST more than ALT, we have only 3-4 diagnoses. One is alcoholic liver disease. Second is end-stage liver disease, cirrhosis. Third is Wilson's disease. But which one among these? Because you see that GGT is raised out of proportion. It is around 7 times in this patient, 364.5. It is out of proportion to that of alkaline phosphatase. So this is most probably an alcoholic liver disease. The only thing which does not goes in favor of alcoholic liver disease, that AST by ALT ratio in most of the alcoholic liver diseases is more than 2:1. Here it is AST by ALT ratio is more than what, but it is not more than 2. AST by ALT ratio is more than 2 in alcoholic liver disease. The differentiation between alcoholic fatty liver disease and non-alcoholic fatty liver disease is that in alcoholic fatty liver disease, AST is higher than ALT, whereas in non-alcoholic fatty liver disease, ALT is higher than AST. So to conclude, whenever we see a liver function test, first we need to identify the pattern. If it is only serum bilirubin which is raised, then we label it as direct or indirect. Whereas when it is elevated enzymes, then the interpretation will be guided by the magnitude of elevation of the respective enzymes rather than which fraction of bilirubin is raised. For example, if it is hepatocellular enzymes are predominantly raised, it will be hepatocellular pattern. Whereas if it will be cholestatic enzymes are raised, it will be cholestatic pattern. Whenever is in confusion, or whenever both the markers are very significantly raised, then we'll calculate the R factor. And also we should remember that the upper limit of normal of these enzymes actually varies with age and gender. Last but not the least, that we should always take into consideration patients' clinical features, history, as well as other lab investigation before a final interpretation is made. Thank you.